Now, meantime, I want to move on to Dr. John Runback. He is with American Endovascular. We were talking about endovascular approaches and limb preservation and the skill set that doctors, you should request of your doctors. And one that I always tell to our friends is you got to make sure that your doctor knows how to perform pedal loop revascularization. Not that it's necessary for you, but you can certainly tell a physician's skill set if they know how to and are willing and have performed pedal loop revascularization. Would you explain why?
Great. So I can just sort of talk about this informally. If you want, I had some slides, which our
Slides are
team has to
great.
put together, whatever you want me to do. So first of all, I just want to, recognize you for all the work you do. It's unbelievable. I mean, I'm really humbled, and have so much admiration for what you built here and continue to build. Second of all, for those of you who are not doctors, you have no idea what luminary physicians you have on this group. I'm looking, I didn't even realize, but these are my colleagues, many of whom I know for a long time, and these really are the best of the best that Kim has managed to pull together. So this is really remarkable. Good to see you guys, all my friends and the Twitterverse and now in the meetings and things. I see at least one patient as well who's had a pedal loop intervention. Still,
yes, Chef
doing
Sarah
well.
Is here.
All right. So that's good to see. So I'll try to get through this quickly. I don't know how much time you want me to spend on this. It's fairly sophisticated, but what I will try to do is kind of speak to this on many levels so that it's understandable. Can you guys see my screen?
Yes.
Excellent. Very good. So let me just make that slide. So as part of American Endovascular and Amputation Prevention, we've had this discussion before. We've done a series of webinars where we talk about these sort of topics, both for referring physicians, podiatrists, as well as for potential patients and their family members. So it's nice to have an opportunity to do this again. I think all the physicians on this call are probably familiar with everything I'm going to say, both in terms of the sort of strategy, the understanding of this process, and of course the technical aspects. And I put this here at our place, but this is true again of all the doctors here, that there's definitely been an evolution in what we're able to do over the last decade, maybe even over the last 5 years, from this idea of treating what's easy, inflow disease, target of opportunity, through to very directed and targeted interventions, as you can sort of see down here: perfusion, directed, angiographically mediated, what I call angiographosome, pedal access, so you get into the artery both above and below the blockage to facilitate crossing that blockage and treating it, or rendezvous procedures, treating multiple vessels to restore the best possible blood flow down to a wound to save that limb. Pedal arch is what we'll be talking about today. And eventually, although we've not had great success, the idea that we can provide biological therapies. We do have some drug delivery, but obviously it's a biological problem. We're still treating this with mechanical tools, but increasingly we're seeing biological solutions as well, both during the procedure and after the procedure, to maintain durability of what we do. Again, the focus of what I was asked to talk about is this part here, the pedal loop or plantar pedal arch or below ankle interventions. And, for those of you who don't know, this is what it looks like. Now, this is a normal. So I never see this other than, on the anatomy diagram like this. I can ask the doctors here, when's the last time they ever saw an angiogram like this? Probably a long time. So these are all named, but I think it speaks to the fact that in the foot, there are multiple blood vessels which stem from the 3 main blood vessels below the knee, which apply different portions of the foot. And that was the concept of what we call angiosomes in the past, or I call angiographosomes, or even more. I gave a talk at a recent meeting where I'm talking about the idea of compartmental perfusion. I think some of these have some of these sort of cases, but if you have a foot on the bottom of the big toe, that's a certain compartment. If you have a flow on the outside of the foot, that's a certain compartment. If it's towards the heel, inside or out, those are different compartments, which have different blood vessels. And what's really interesting is very often you'll see somebody, you have a wound, and they will say they feel a pulse, so you can't have peripheral artery disease. But take a look at this picture. Let's say your wound is here, and this artery is blocked, and this artery is blocked, but you feel a pulse there. It means nothing. And the fact is, the wound is supplied in a very specific way from arteries that may be blocked, and feeling a pulse in other arterial distribution does not mean that you don't have any other blockages that are causing peripheral arterial disease. So the whole idea that understanding that blood flow to different portions of the foot is compartmentalized or regionalized is really important. Is a lot of the foundation for considering plantar pedal arch or below the ankle interventions. Here's just another, picture again. A lot of blood vessels here, guys, right? All with a lot of names. And certainly over the last 5 years, 10 years, for those of us who do this, becoming familiar with this anatomy in a very detailed sort of way has been a crucial part of achieving success. Superficial arches, deep in, I've already said this. So these are sort of the questions I think that I was told to address. Pedal loop questions. What's possible? What does it look like? Who should have it done? Why is it controversial? How do you, as patients, know if you need this? Do you do it if you have numb toes? How is it done? Which is a little bit how it does look like, and who should you see? So I'm going to try to address all of these as I go through it, and I have the same slide at the end with my view, my perspective on the answers. So the pedal arch is the connection between the artery and the top of the foot, which is called the dorsalis pedis artery, and one of the two arteries on the bottom of the foot, which is the lateral plantar artery, which goes lateral to outside, which makes two 90-degree turns. The artery on top of the foot actually comes down where it goes to the space between the first and second toes. It penetrates, goes 90 degrees towards the floor, where it's called the plantar perforating artery. It then turns 90 degrees towards the outside of the foot, where it connects to the lateral plantar artery. And then it comes back on an angle to the inside, even though it went to the outside first, to the inside of your ankle over the medial malleolus, which is the bone on the inside of your ankle. So a lot of sort of sharp turns, and that's the plantar pedal arch. There's another artery which comes from the posterior tibial, which is on the inside of your leg, which then goes on the bottom of the surface on the inside or medial aspect of your leg. And that's actually equally important because that's the artery that will go, for instance, directly, in most instances, without variation, to the base of the big toe, where we very commonly see wounds. So again, a different sort of compartment. The whole idea of plantar pedal arch integrity is based upon this whole idea. Type 1 is it's intact. Here's the top, here's the bottom, there's the plantar perforating segment. This is just a lateral sideways view. It's intact arch. The 2A is only the top's intact. 2B is only the bottom's intact. And type 3, which sort of gets in this idea of a desert foot, is where neither the dorsal or the plantar circulation is intact out to the forefoot and out to the digits. Obviously, this is better and this is worse. And there's been a strong correlation between the integrity of the pedal arch or plantar pedal arch and subsequent wound healing and prevention of amputation, as you see over here. So if you have a type 1 arch where everything's intact, wound healing occurs 90% of the time. If you have a type 3 arch, wound healing occurs 60% of the time, and often with repeated intervention. These patients need repeat intervention 40% of the time in large studies. Here you're going to sort of see some other things. So two things is, one is angiosome versus non-angiosome. In other words, the idea of targeting, the right vessel. Yes, super important in the short term, but over the long term, a little less important because collateral is open. But the idea of restoring a complete arch maintains its importance even as you get out to a year and a half, more or less. Again, this would be a type 1 having a complete arch over here as opposed to a partially complete arch or an absent arch. So again, a lot of publication which supports this is actually in patients who have had surgical bypass, what the arch is like downstream. Here again, you see this is the patients who have a complete arch, a partial arch, or an absent arch. Clearly a difference, in limb salvage. No difference in graft patency, but there's definitely a difference in limb salvage as well as reintervention. So how do we do it? Well, it's like that old joke, how do you get to Carnegie Hall? Practice, 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 right? So these are very, very sophisticated techniques and require equally sophisticated tools and understanding of how to best utilize these tools and strategies to achieve success, even in most complex scenarios. So that being said, we say that we're successful 80 to 90% of the time. We're not yet quite at 100% of the time, as much as we would like to, because of limitations in, tool set more than skill set. Obviously, we have very, very small catheters. To give you an idea, a French is 1/3 of a millimeter. So this is less than a millimeter in diameter. This is inches over here, very, very thin wires are the ones that we like. Bidirectional means you come from that artery to the top of the foot as well as the artery at the bottom of the foot with 2 wires directed downward from the groin. Sometimes you have to get into the artery below the obstruction. and go back. And those are rendezvous procedures, so you can do that around the arch. Here's some sort of concepts about taking pictures in multiple views, not just one view, so you can better appreciate the complexities of the anatomy. And you can follow this whole idea of woundosome, angiographosome, or target artery path by injecting contrast and seeing what is the real artery to the wounds and not just one you might anticipate off the cuff. And really, once again, the plantar pedal arch, you got to be very, very careful that you stay within the center of the artery, because you start to get into the wall of the artery, you can start blocking the little branches which come off, which might be crucial to supply blood flow out to the digits. So if you find that you're getting into the wall of the artery in this particular distribution, you cannot proceed. Whereas, higher up, those small branches are a little less relevant. So here's sort of how you do it. Here's an angiogram. You can see, and I just kind of bring this very, very tiny kind of wire down, very, very slowly. Art Lee's done a lot of this. He just has a great graphic presentation. Usually I'm not taking, images of this. I'm watching it on fluoroscopy, not saving them. So he's saved them. You can see how you sort of sequentially advance this wire. Sometimes, this is one coming from the other side where you kind of can loop your wire and kind of create this knuckle configuration. So this is coming from the dorsalis pedis on the left. This one on the right is coming from the posterior tibia. We can see the loop now comes around this. That knuckle is sort of nice, that it assures that you stay centrally within the vessel. You have to get in here again, do a lot of different pictures in different views to better identify what I call this bridge over here. This is the plantar perforating segment. It's always between the base of the first and second metatarsals. This is the lateral plantar, which is coming over here through this plantar perforating segment to find what looks like a figure of 8 in the frontal view. We're now, of course, back up here in dorsalis pedis artery. Again, very, very sophisticated stuff. And here you can see that that's been done. And this helps by doing very selective injections of contrast and multiple injections as you go. So I think you guys are appreciating, the level of complexity that can be involved in treating these arteries, which are often maybe 2-millimeter arteries or smaller. Okay, and I love these drawings by Dr. Lee, who's down in Gainesville, where you look at what you have, and then you apply kind of your knowledge, your conceptual map of where these arteries should be, so that you can try to cross them. I mean, obviously, a key part to success is knowing where you're aiming, right? So this is sort of like shooting at a target in the fog. If you don't know where you're aiming, then you'll never get there. If you have an idea where the target is, then you can sort of shoot, take a step closer, shoot a step closer until you actually see the target and can be right on. By the way, I see there are chats. I'm not looking at the questions now as I'm presenting, but I will try to address them. And you can see how this sort of concept of sort of anticipating the course of things works, so that you can kind of work your way through these occluded segments. This can be sometimes be done with more than one wire, bidirectionally, working from the artery over the top of the foot, as well as the artery on the bottom of the foot, whatever you need to sort of get across it. And what we refer to at the point of blockages are these caps, or these either calcified or fibrous, portions of the blood vessel, which are restricting the blood flow and restricting our tools from crossing. And sometimes it's easier to cross a cap in one direction than the other. This idea of using multiple approaches to it to get across it really is sort of key. And if you do this a lot, this is a good example of the type of results that you can get. And if you look at the left, not only do you not have a complete arch in this front view, but you'll see there's no flow out to the toes. And look at how magically things light up once you get restored blood flow to this arch. Not only you get the arch, but you now get all this flow out to these toes, which is all the difference between losing and saving a limb. Here's an example as well. You can't see all my writing over here, but this is what I call diligent intervention. So this is a patient who, of the 3 vessels below the foot, only one is open. The one that goes to the ankle has a little branch which connects to the one that goes to the inside of the ankle down. The top of the artery is closed, a little wisp of it over here. And utilizing a number of techniques where we've gotten in the artery below the blockage here at the ankle. So we have a catheter both in the artery by the hip, directed down towards the foot, and the catheter in the foot now directed up. You can see this one's working down, this one's working up. And we go ahead working from kind of both sides. Here we've actually gone in again for the top of the foot. We're doing everything we need to do, guys, to try to get this flow out to where this patient's wound is. And this is key. You can't be faint of heart doing these things. You have to have a tremendous amount of diligence, and you need to have a stepwise logical progression of ideas and skill set when one thing doesn't fail. The greatest thing I've learned is, plan A, plan B, plan C, plan Z often will allow success when others don't. In this case, we can do the rendezvous in this distribution with the artery entering the artery from below. We're able to pass a very fine wire from below into a little catheter or hollow straw from above. Once you do that, have now wire at both ends, at the hip and at the foot. This is a orbital atherectomy in this case, in this calcified vessel. You actually can make out some calcium. That little gray stuff there is calcium on the wall of the blood vessel. And that helps to sand away some of that calcium. And then you go ahead, we manage to cross this loop and we balloon, but we get an area here where we can't pass the balloon. As a result, this looks really good, but we do not restore the pedal arch. What do? We focus on that area in this particular case with a very focal force balloon and complete the pedal arch and get this sort of result. So again, speaks to some of the kind of diligent interventions which might be necessary. How about this patient over here? Oh, sorry, go back one. Again, I can't read my writing. I don't know why this is blocking me here, but let me see if we can shrink this down. Just over here, okay. 57-year-old person with gangrene of the first to fourth digits. I should have taken that picture for you guys. You can see that they have a lot of risk factors, previous heart bypass, heart attack, insulin-dependent diabetes mellitus, hypertension. This is one of these cases where, you know, the doctor said, I don't know, I can feel a pulse over here. The problem is there's no pulse over here. And that's going to be the artery which contributes to wound supply. And what's interesting to me in these cases, you don't even appreciate necessarily where the relevant contribution is. So when we come down here and we sort of cross this now from both sides and get around this pedal arch, as you can see over here, in this case, doing some atherectomy, restore this. But what's important is that you wouldn't have appreciated before that the arteries you had were not sufficient to drive blood flow out to the toes. It looked like you had one good artery, right? But what happens is when you rebuild this bridge, this plantar perforating segment, that's often this point at which you get the origins of these toe vessels or metatarsal arteries. And here you can see the wound blush. So by completing this plantar pedal arch in this case, it made all the difference to this patient to get all the way out. Here's another one. Go through these quickly. This is a patient who has a very, very painful wound. And I like this case because it sort of shows how we need to be creative and adaptive as we're doing our procedures. This is a patient who actually had a prior pedal arch angioplasty and then had the amputation of the hallux. I think somebody mentioned earlier during discussion, it's important to restore blood flow to that bottom of the foot, because if you're going to have a minor amputation or need a transmetatarsal amputation, because there's infection or gangrene that can't be saved, you still need the flow on the bottom of the foot because you get a plantar flap. You can fold up the skin on the bottom of the foot to preserve a working surface. And you do that so that the suture line is on the top of the foot. You're not bearing weight on it. So you need flow to the bottom of that foot to allow subsequent minor, but limb preserving amputation. This patient had a pedal arch amputation. They sealed the hallux, but this is a very, very painful wound here, which actually probes almost to bone. As you guys with diabetes patients may know, these can be very deceptive how bad these are. So this is one where we kind of look at the deep arch. So here's a patient, we sort of come down in, and the wound is down over here. You can see on our selective angiograms how there's a reduced blood flow to the wound. Sure, there's blood flow here, there's blood flow here, over here by the ankle, but where we need it, there's reduced blood flow to the wound. So this is when we've gone ahead now, we've done the plantar pedal arch reconstruction. So here's the superficial arch. That looks great, right? That's what we just showed you. Will this do the job? Well, often it will, but more for forefoot wounds, particularly, kind of third through fifth toes and plantar wounds, than, it will do for hindfoot or medial hindfoot wounds, which are a separate compartment. So in this particular case, this wasn't necessarily enough. There's microcirculatory disturbance, and this artery, which comes to medial plantar, tells you where it's going. The inside, on the bottom, directly where that wound is blocked. And unfortunately, in patients with diabetes and patients with chronic kidney disease, they don't make new blood vessels. They don't collateralize like a normal, healthy person would. So what do we do? Again, we recognize the problem. We get specifically into that artery through the wound. This is my angiographosome or target artery path. By opening up that artery to the wound, we now recruit all these collaterals with direct flow to that wound. See how it's lighting up? Which wasn't even visible before. Again, so that's a deep arch intervention. You can see it in two separate views here, how we restored flow.
That's amazing. Oh my goodness. And really quickly, as we wrap up here, I know you have another slide, but just want to, why is it so controversial, and why do some doctors say this is impossible? You can't do this.
So let me just jump to the answers to the questions, right? So what's possible? Well, yeah, obviously it's individualized, but we can do amazing things. I think I've shown some examples here, Kim, and I think a key thing is the doctors on this call will all do this sort of work, maybe not as a first treatment, but as a second treatment for sure if it's needed. But you need to get a doctor who's familiar with these sort of things, particularly if you had prior intervention, which has not resulted in healing of the wound. What does it look like? I said treating the arteries of the foot. I'm getting to your controversial question in a moment. Who's it right for? The data suggests you don't necessarily need it as a first treatment for everybody. But if you have renal disease, wounds that aren't healing, and larger wounds, it's definitely something that should be considered up front. Why is it controversial? That's a great question. I think the biggest thing is not many doctors are trained on this or have comfort with it. And if you're not familiar or comfortable with something, the natural tendency is to say that it may not be beneficial. Not to mention the fact, if you're not comfortable with it, it may be prone to causing complications, worsening of the circulation, forming clots or blocking blood vessels that were otherwise, open. And then finally, there's this idea that you might need a surgical bypass, that this can block or somehow damage the artery to which a surgical bypass would go. But that really isn't true. Most of these patients are not even candidates for surgical bypass for a variety of reasons. So I think that's why it's controversial. The biggest thing is, you need to have somebody who's really, really, really comfortable with this, has done it quite a bit, so you can utilize all these techniques. Just two things on here. I have numb toes. Is this right for me? Probably not. Just as a general rule, when we do lower extremity interventions, it's for patients who have critical limb ischemia or below the knee. And that's patients who either have pain that wakes them from sleep at night, they just cannot sleep, or wounds that aren't healing or infection or something like that. Numbness, particularly this population, is often due to neuropathy. You have to make sure that, this is not neuropathic pain, because numb toes alone is not sufficient, because these procedures, as I mentioned, can be prone to some challenges and some problems. So you don't want to do it unless it's absolutely necessary. So hopefully I've addressed most of the questions here. I wrote American Endovascular, but any of the doctors on this call would be excellent for this. Clearly, you have a remarkable group of physicians that you work with, and we're glad to be a part of this group.
Yeah, every single one of the vascular specialists here is trained in pedal loop revascularization, if in fact it's necessary. That's why I always say that when you choose a doctor, whether it's a vascular surgeon, interventional radiologist, or interventional cardiologist, it's a good question to ask if they are trained in it, because long term, if you need it, you want a doctor that can do it if necessary to save your life and limb. Dr. Runback, thank you so much. We really appreciate you. I know that Sarah wants to jump in really quick and say a few words. Chef Sarah, would you mind? She is one of your patients, actually.
Hi, yes. First of all, Kim, thank you again for this tremendous opportunity. And Dr. Runback, oh my gosh. I mean, it's not even enough word to say how grateful I am for you to really kind of save my leg. Like now I'm able to walk without a cane, maybe not rollerblading. We talk about that, but I'm doing much better. And you know what? I'm so, so, so happy. So guys, this is September, and September is the month awareness for PAD. So September champion is our Dr. Runback. Congratulations! Yay!
Shall we do this? There you go.
Congratulations, Dr. Runback. You are the Way to My Heart's PAD champion for PAD Awareness Month.
Thank you. Thank you, Sarah.
You're welcome.
You're our champion patient.
She is. Did you see she did a record 20,000 steps the other day?
Wow. That is a record.
Yes, I did, because of you.
Don't get a wound.
No.
No. I'm good. I see you soon for the appointment. I have a big story to talk about, but I see
Very
you.
good.
It'll come. Thank you so much, Sarah. And thank you so much, Dr. Runback. We really appreciate you, our PAD Awareness Month for 2021, our PAD champion. Thank you so much.